Hello, dear friends and colleagues. Today I am going to talk about an important topic which is tested in MRCP Part 1, Part 2, and PCS examination and any entrance examination. You will get Pheochromocytoma. So, Pheochromocytoma is the tumor of chromaffin cell in the adrenal medulla. So, what is chromaffin cell? Chromaffin cell is modified postganglionic sympathetic cell which is related to secretions of the adrenaline, and most of the adrenaline in our body secreted from this chromaffin cell adrenal medulla, 90%, and 10% non-adrenaline. So pheochromocytoma is the tumor of this chromaffin cell, and this interestingly this adrenal medulla is developed from neuroectoderm. This is basic. This adrenaline is a stress hormone. It works on alpha and beta receptor. In vessels there is alpha receptor, so when it stimulates it causes vasoconstriction. In the heart there is beta receptor. When it stimulates it increases the force of contractions of the heart and increase the heart rate. So when it is excess adrenaline in the body produced from the pheochromocytoma, all the excessive symptoms of adrenaline you will get. So to remember the sign symptoms, just remember the first letter of pheochromocytoma, P. So first P is pain, that means headache. Most common presentations of pheochromocytoma is headache. Second P, pressure. This is also most common association, but sometimes it can be asymptomatic. For that reason, headache is the most common presentation. Okay, and interestingly, this pressure hypertension is episodic. Sometimes you will get normal pressure, sometimes you will get high blood pressure, and patient may say that I have hypertension. Sometimes it is normal, sometimes it is high. Even I had taken some antihypertensive, after getting it is not reducing, rather it is increasing. This is clue. You just think about pheochromocytoma. Third P is palpitation, that is abnormal awareness of the heartbeat, not necessarily that you are having palpitation, that is having tachycardia or bradycardia. Okay. Fourth P is perspiration. Patient will present with excessive sweating. Fifth P is panic. Patient will be panic, and this panic patient may this abnormal sensation, restless, panic. So it is one of the presentations also in cerebral gait. And pallor. Sometimes patient may present with pallor. Pale. So remember the 6P, will never forget the sign symptoms of pheochromocytoma. Okay. Second, just remember 10% rule. In pheochromocytoma, it follow 10% rule. That is 10% bilateral, 10% malignant, 10% familial, 10% extra-adrenal, and 10% in case of children. So just remember the 10% rule. Sometimes patient may ask whether there is a chance of malignancy or not. Your answer will be yes, there is chance. It is 10% chance that you may this tumor may be malignant, though 90% is benign. So here there will be a question: where is the most common site of extra-adrenal pheochromocytoma? Your answer will be it is in the or adjacent the bifurcations of the aorta, and the name is organ of Zucker. Okay, just remember Zuckerberg, Mark Zuckerberg, Zucker. Okay, so this is a question. The where will be the most common site of pheochromocytoma, extra-adrenal pheochromocytoma. Okay, now uh, what will be the investigation, screening investigations? So sometimes in scenario there will be several options, and one option will be the 24-hour urinary catecholamine. It is wrong. You just remember 24-hour urinary metanephrine. It is the answer. Second investigation will be the MIBG scan, that is meta-iodobenzyl guanidine scan. There is some radioisotope which will accumulate to the chromaffin cell where is in the body. So it will detect the all locations of the pheochromocytoma. It may be extra-adrenal or adrenal. Okay, so MIBG scan. It is 90% sensitive, but another 100% sensitive is FDOPA PET or CT scan. But it is it is not available test, so rarely done. Will not remember this. Okay. Third is CT scan or MRI to locate the tumors in the abdomen, the tumors in the adrenal gland. Okay. So if question will be is 24-hour metanephrine or 24-hour catecholamine, your answer will be 24-hour urinary metanephrine. Okay. Now regarding treatment, pheochromocytoma, I mention in that first scenario the pressure will be fluctuating and patient will say that my after taking antihypertensive my blood pressure increase rather than decrease. Why? Because that doctor prescribed beta blocker. If you prescribe beta blocker fast, the unopposed alpha activity can give rise hypertensive crisis. So your knowledge will be tested here is whether it is alpha blocker or beta blocker you will prescribe first. Yes, just remember chronological, alphabetic chronological. Chronologically, you just remember A for alpha, B for beta. So A will come first and B will come last. So A alpha blocker, that is phenoxybenjamin, will be prescribed first and beta blocker will be prescribed last. So that patient prescribed beta blocker, for that reason his blood pressure increased, okay, rather than decreased. So your answer will be the first prescribed antihypertensive is alpha blocker, that is phenoxybenjamin. Again remember P. P is phenoxybenjamin. P first letter. Second thing is treatment. Again P. Procedure. What is procedure? Surgical procedures. So surgical procedures, you have to remove this pheochromocytoma by surgically. Okay. Other options also are there like chemotherapy, radiotherapy, but it will be tested whether you'll prescribe alpha blocker first or beta blocker first. One thing, and before surgery also you have to give treatment with alpha blocker first, beta blocker first. Then when it will be stable, then go for surgery. Otherwise, there are a lot of adrenaline in the stored adrenaline. When it will handle the gland, lot of adrenaline will secrete and patient will go for hypertensive crisis. Okay. Now there are some association with pheochromocytoma, so you have to remember this. Don't forget these three diseases with which is associated with pheochromocytoma. One is MEN2, another is neurofibromatosis, and third one is von Hippel-Lindau syndrome. So there will be symptoms of MEN2A and 2B. 2A, 2B actually will be discussed in my next video, men, and Pheochromocytoma, this association, they will ask question like that. Pheochromocytoma is associated with Horny syndrome or neurofibromatosis or men 2. Sometimes they will give some other things. So if these three, actually there will be one association will be given and four others will be other association. For example, in exam you have to choose the best of 5. So when there will be questions in scenario, maybe they said that pheochromocytoma is associated with men 2b, men 2, men 1, glucagonoma, pituitary tumor, like this. So in this you have to remember men 2b. Okay. So this association, this area will be tested. So one question from here also. So one question for symptoms, most common presentation headache. One question for investigation. 24 hours metanephrine, urinary metanephrine. One question from treatment, alpha blocker first or beta blocker first. Another question with association. Okay. So in pheochromocytoma, you just remember this thing. I think you will get all the thing, all the question, but I'd like to give some basic also. Two adrenal gland located on the top of the two kidneys. It has adrenal cortex and medulla. From medulla, adrenaline, non-adrenaline secreting. Adrenaline is more, 90%, non-adrenaline 10% only. And in cortex there are 3 layers. Just remember GFR, ACD. G for zona glomerulosa, F for zona fasciculata, and R for zona reticularis. And secreted zona glomerulosa, G, A for ACD, A for aldosterone, C for corticosterone, and D for dihydroepiandrosterone, that is, it is a sex hormone. So GFR, ACD, just remember the functions of the adrenal cortex. And adrenal medulla already I discussed about, that is adrenaline secreting part of the body, and it is developed from neuroectoderm. And interestingly, the adrenal gland is supplied by arteries. So you will get blood supply artery, 3 arteries: superior, middle, and inferior adrenal artery from the periphery of the adrenal gland, but one vein, it is come out from medulla. So there is 3 arteries supplied to the adrenal gland and one vein. So that vein actually is left vein drain into the renal vein, but right vein is directly to the inferior vena cava, because inferior vena cava is situated in the right side, so nearer it is directly drain. And superior adrenal suprarenal artery, adrenal artery, it is a branch of inferior phrenic artery. It's not necessary to remember, just middle branch of abdominal artery and inferior branch of renal artery. It is not so important, but sometimes for entrance examination your anatomical knowledge can be tested. For that reason I like to mention, I just mentioned that. Okay. So in hilum, one vein, lymph node, lymph and vein drain from the hilum, drain to the vein from hilum. Okay. So now I am just summarizing in one sentence. Adrenal gland pheochromocytoma in one sentence. The tumors of the adrenal medulla originated from chromatin cell is pheochromocytoma. It is developed, that chromatin cell developed from a neuroectoderm, and it is a modified post-ganglionic sympathetic cell. Most of the adrenal secretion come from this chromatin cell, that is adrenal medulla. no, non-adrenaline 10%, adrenaline 90%. Okay, and excessive adrenaline causing all the symptoms. Remember 6P: pressure, pain, palpitation, perspiration, pallor, and panic. Follow the 10% rule: 10% bilateral, 10% malignant, 10% familial, 10% extra-adrenal, and 10% children. Remember the investigations is 24-hour urinary metanephrine, MIBG scan, CT scan. Treatment: alpha blocker first, beta blocker second. Alpha blocker is phenoxybenzaimine, which is started also with P. Then another P, last treatment also, that is procedure, surgical resection. Other treatment also available, that is chemotherapy and radiotherapy. And remember the some associations, which is uh, associated pheochromocytoma is associated main 2A and 2B, neurofibromatosis and von Hippel-Lindau syndrome. And extra-adrenal most common site is adjacent to the bifurcations of the aorta, organ of Zucker-Kandel. My next video will be on multiple endocrine neoplasia. Hopefully will be with me, and subscribe my channel to get this type of video. Thank you very much.